Gastrointestinal examination. I begin by washing my hands and obtaining consent from the patient to perform the examination. For the general inspection, the patient does not appear to be in acute distress. There's no profuse sweating or paleness of the skin that could be indicative of pancreatitis. If the patient is writhing in bed, that could indicate biliary colic, and if the patient is in fetal position, it could suggest peritonitis or perforation. If the patient appears cachectic, think of possible malignancy. I'm checking to see if there's any angular fissures of the corner of the mouth or glossitis, which suggests iron or vitamin B12 deficiency. I'm looking for any signs of central or peripheral cyanosis, which could be due to secondary causes of hypoxemia. I'm also looking at the conjunctiva for pallor, which would be indicative of anemia or yellowish discoloration of the sclera, which would suggest jaundice. Looking at the palms, I see no palmar erythema, which would suggest liver disease, as well as no Dupuytren's contractures, which is thickening of the palmar fascia suggestive of alcohol abuse. There's no spooning of the nails or koilonychia indicative of anemia, and no whitening of nails or leukonychia, which indicates hypoalbuminemia or malnutrition. I'm checking for signs of clubbing. If the Lovibond angle is greater than 180 degrees, it could indicate cirrhosis, irritable bowel disease, or amyloidosis. Looking for resting tremors, which would indicate alcohol withdrawal, as well as flapping tremors or hysterexis indicating hepatic encephalopathy or liver failure. Finally, I'll check for pitting edema by pressing over the proximal tibia for 5 seconds. If it's present, it can suggest portal hypertension and right-sided heart failure. For abdominal examination, the patient should be in supine position with hands by the side and legs uncrossed. I'm looking at the contour of the abdomen at eye level. It should be flat or scaphoid and symmetrical. If not, this can suggest hernias, enlarged organs, or masses. I'm going to ask the patient to cough. If a protrusion increases in size, it could be a hernia. If it's due to a mass, the size does not change. If the abdomen is distended, think of gas, fat, fluid, or feces accumulation. I'm looking for any scars and noting their location and size. Purple striae indicate Cushing syndrome. Look for Cullen sign, which is ecchymosis periumbilically, or Gray-Turner sign, which is ecchymosis in the flank regions and can indicate retroperitoneal hemorrhage. I'm also looking for peristaltic waves over several minutes. If it is observed, it can indicate intestinal obstruction. Also checking for engorged paraumbilical veins radiating from the umbilicus. If present, think of caput medusa due to portal hypertension or IVC obstruction. For auscultation, I'm warming my stethoscope to avoid any spasms and placing the diaphragm in the right lower quadrant and moving in a clockwise manner. I'm listening to the bowel sounds and noting character and frequency. Normal bowel sounds consist of clicks and gurgles occurring every 5 to 10 seconds or 5 to 34 bowel sounds per minute. Borborygmi or stomach growling are long and loud gurgles of hyperperistalsis from increased intestinal motility. Bowel sounds are increased in diarrhea and acute intestinal obstructions. If no sounds are heard after 2 minutes, this is paralytic ileus. Moving on to brute auscultation. I will auscultate for brutes, which are vascular or whooshing sounds with the diaphragm. Auscultate over the aorta by moving 2 inches above the umbilicus. Normally, these sounds are heard only during systole, and if heard during systole and diastole, this can indicate an abdominal aortic aneurysm or partial arterial obstruction. Now moving 2 centimeters laterally from the aortic site and listening over the right renal artery for brutes present in systole and diastole, which indicates renal artery stenosis. I am listening for brutes over the left renal artery by repeating the same process. Placing the diaphragm below and lateral to the umbilicus on each side to auscultate for brutes over the right and left iliac arteries. Now I'm placing the diaphragm below the inguinal ligament about midway between the pubic symphysis and anterior superior iliac spine to auscultate for the right and left femoral arteries. Once again, brutes heard over systole and diastole are abnormal and could indicate partial arterial occlusion or aneurysms. Peritoneal friction rubs and venous hum. Friction rubs are leathery grating quality sounds due to inflammation of the organs. I will ask the patient to breathe in and out through the mouth and auscultate with the diaphragm over the right upper quadrant, and if it is present, it is called hepatic friction rub and could be due to liver biopsy, perihepatitis from gonococcal or chlamydial infection, and if it is accompanied by a brute, consider liver malignancy. Listening over the left upper quadrant or spleen area, if sounds are present, it is called splenic friction rub, possibly due to splenic infarction. Listening for venous hum near the umbilical area, it is a humming or roaring sounds due to increased collateral circulation between portal and systemic circulation as seen in patients with portal hypertension. Succussion splash. I will be using one hand to place down the stethoscope and hold the abdomen in position and use my other hand to shake the patient side to side lightly. A sloshing sound indicates distension of the stomach, usually from gas or fluid retained proximal to the obstructed organ as seen in gastric outlet obstruction. Percussion. I am now percussing each quadrant starting at the right lower quadrant and moving clockwise. Right lower quadrant should be tympanic due to the intestines being filled with air. The right upper quadrant is dull due to presence of the liver. Left upper quadrant is tympanic due to the stomach. Left lower quadrant should be tympanic, or it could be dull due to presence of feces. I'm going to keep percussing towards the umbilicus and go up to the aorta. Normally there should be predominance of tympany. Flank dullness can indicate ascites. Any areas of localized dullness could raise suspicion of masses. I'm also evaluating for situs inversus. Palpation. Beginning with light palpation, I'm going to have the patient place their arms by their sides and bend the knees and breathe in and out through the mouth as I palpate. Expiration helps relax abdominal muscles. I am making sure my hands are warm, and I'm going to slowly and lightly palpate with one hand using the surface of my finger pads in circular motions over all the 9 quadrants in a clockwise order. I am talking to the patient while doing this. It will help distract them and keep the muscles relaxed. I'm looking for areas of superficial tenderness by looking at the patient's facial expressions. If there is localized tenderness, it could be appendicitis or cholecystitis, and it is confirmed by having the patient cough and asking them if it hurts. If the patient localizes the pain with coughing, try to map out the boundaries and tenderness with one finger. Feel for muscular resistance. If it is present, distinguish from voluntary and involuntary rigidity. Voluntary decreases with relaxation of the abdominal muscles, while involuntary persists and can be seen in peritonitis. It is a board-like rigidity and is diffuse. Now performing deep palpation. Using both hands, I'm going to place my right hand on the abdomen and left hand on top of the right as I palpate with the right and use the left to exert pressure. Try to identify deep masses like neoplasms over the right upper quadrant, abdominal aortic aneurysms over the epigastrium, diverticulitis over the left lower quadrant, or distended bladder over the pubis. Note their location, size, shape, consistency, tenderness, whether they're pulsatile, and their mobility. Rebound tenderness. Over the area of suspicion, for example at the right lower quadrant, I'm going to gently press slowly and firmly and quickly release. Pain is more upon release of the hand due to rapid movement of the inflamed peritoneum. Now evaluating for referred rebound tenderness. If the area of suspicion is on the right lower quadrant, press on the left lower quadrant with the same technique, and if the pain is felt in the right lower quadrant upon quick release of my hand, it is seen in acute appendicitis. If pain is felt in the right lower quadrant while applying initial pressure but before the quick release of my hand, it is called Rovsing sign. Evaluating for obturator sign now. I am going to rotate the patient's right leg at the hip with a flexed knee. If the inflamed appendix is in the pelvic position, pain occurs at the right lower quadrant due to irritation of the obturator internus muscle. This is a positive obturator sign. Psoas sign. I'm going to have the patient turn to their left side and extend the patient's right leg at the hip. If the inflamed appendix is in the retrocecal position, it produces right lower quadrant pain and is due to irritation of the psoas muscle from the inflammation, and upon stretching the pain localizes. Special tests. For liver percussion, I'm percussing along the midclavicular line on the right side around where the mid-lung field is and moving downward, covering all spaces until the resonant note becomes dull, which indicates the upper border of the liver, and now I'm marking it. Now starting around the level of the umbilicus and moving upward until the tympanic note becomes dull. This indicates the lower border of the liver. I'm going to mark it as well. I'm measuring the distance between these 2 points. A normal distance between them should be 6 to 12 centimeters at the right midclavicular line. If the distance is increased, it can indicate hepatomegaly, and if distance is decreased, it can happen because of free air present in the abdomen below the diaphragm, as seen in ruptured stomach from ulcers. Also, gas in the colon can falsely decrease the liver size. Liver palpation. I'm going to ask the patient to flex their knees and place my left hand on their back parallel to the 11th and 12th ribs and pressing up. I will place my right hand under the costal margin with fingers pointing towards the right shoulder, and I'm going to ask the patient to take a deep breath in and feel for the liver edge with the tip of my fingers. I'm feeling for the anterior surface of the liver. The liver should be normally palpable, and a normal liver edge is soft, sharp-edged and regular with a smooth surface. A pulsatile liver could indicate tricuspid regurgitation. Tender hepatomegaly could indicate right heart failure or hepatitis. Percussion of spleen. Starting at the jugular notch, I'm sliding down 5 centimeters to the sternal angle and moving laterally to the left to find the 2nd rib, and I'm counting down until the 6th rib. This marks the superior border of Traub space, which is demarcated superiorly by the 6th rib, laterally by the left anterior axillary line, and inferiorly by the left costal margin. I will percuss at this space with the patient breathing normally. There should be a tympanic note throughout due to the stomach. I am noting the lateral extent of the tympanic note. Then I'll ask the patient to take a deep breath and percuss again. Tympany should remain, and if it becomes dull on deep inspiration, it suggests splenomegaly. For spleen palpation, I'm going to ask the patient to bend their knees and I will support and lift up the left lower rib cage with my left hand while the patient is supine and ask the patient to take a deep breath and palpate in circular motions upwards toward the spleen with my right hand starting at the right lower quadrant and moving diagonally to the left costal margin. Usually the spleen is not palpable, but if it is, note tenderness and assess the contour. If it is enlarged, it's usually palpable 2 cm below the left costal margin on deep inspiration. Kidney palpation. With the patient's knees bent, I will be placing my left hand on the back just below the right 12th rib and lifting upwards. I will ask the patient to take a deep breath and palpate deeply with my right hand in the right upper quadrant just below the costal margin and try to capture the kidney between both hands. Ask the patient to breathe out and stop. The kidney may be felt to slip from the hands during exhalation. Note the size, contour, and tenderness of the palpable kidney. It might be abnormal in conditions like hydronephrosis or polycystic kidney disease. Examination of the aorta. I'm pressing down deeply slightly left of the midline 2 inches above the umbilicus with one hand on each side of the aorta and identifying the aortic pulsation, which is usually felt on most individuals. A well-defined pulsatile mass that is greater than 3 cm across suggests abdominal aortic aneurysm, which is mainly due to atherosclerosis. Percussion for ascites. I will start percussing from the umbilicus outwards and noting when the tympanic note changes to dullness. Usually in ascites the dull note should start coming closer towards the midline, indicating fluid accumulation. I'm making sure to cover all around the abdomen and noting the points of transition. Now evaluating for shifting dullness, I'm going to have the patient turn to their left side and I will start percussing from the center outwards. Because of gravity, dullness shifts to the more dependent side, while tympany shifts to the top. Now evaluating the kidneys for costovertebral angle tenderness. I'm going to ask the patient to sit on the side of the bed with his back facing me and I will locate the 12th rib. I will place my left hand at the costovertebral angle and with my right hand I'm going to strike gently with the ulnar side of my fist. Pain with CVA tenderness indicates pyelonephritis. Evaluating for Virchow's lymph nodes. I will have the patient sit on the bed and I will palpate over the supraclavicular area, noting if there's any lymph nodes present and if they are, note their size, shape, location, consistency, tenderness, and mobility. If they're present, it could indicate gastric or pancreatic carcinoma. This concludes the examination.